This is Joy Duff Schultz presenting my PowerPoint on barriers to healthcare access in rural America. The three barriers that I chose to look at in regards to accessing healthcare in rural America are the healthcare provider shortage, transportation barriers, and the availability of the internet and access to telemedicine. America is already experiencing a healthcare provider shortage. The distribution of primary care providers is already limited and particularly strained in rural and underserved areas, which makes accessing qualified and efficient primary care a growing concern. Currently, most primary care services are provided by physicians, but yet only 10% of physicians are practicing in rural areas. A recent study from the Association of American Medical College found that there has been a 27% decrease in medical graduates that are choosing primary care as their career. HRSA estimates that by 2020, there will be a shortage of 20,400 primary care physicians in the United States. Now, even though that estimate relies solely on primary care physicians, it does not take into account that other services being provided by like physician's assistants or advanced practice nurses. However, out of the 80% of nurses practitioners that work in a primary care setting, only 15% of them are working in rural areas. After the creation of the ACA in 2010, there's been a much greater demand for healthcare services without the infrastructure or workforce to meet those demands. About 8 to 9 more million rural residents are now eligible for health care coverage, yet recruitment and retention of providers to rural areas continues to be a barrier. Transportation barriers are often cited as a barrier to health care access. Transportation barriers can create problems with scheduled appointments, time frames of care delivery, and with having availability or access to pharmacies and getting medication. Transportation barriers can also cause delays in emergency care. Rural patients report more problems related to transportation barriers compared to their urban counterparts. They report a higher burden of travel for healthcare when measured by distance and time. Studies have showed that an increased time required for travel and the perceived difficulty in traveling to see a doctor are prohibitive. Since rural residents often have a lower socioeconomic status, they may lack the resources to have access to a vehicle or own their own vehicle, afford the cost of fuel, or even have money to pay for public transit. There has been a positive association that shows that having access to a vehicle improves access to health care. One study showed that 82% of those that made their medical appointments had access to a car, and that means either owning one themselves or having access to one through a family or a friend. But 58% of those who did not keep their medical appointments did not have access to a vehicle. Also, those that possess a driver's license are twice as likely to attend medical appointments than patients that did not have a driver's license. Innovations in technology have the potential to help improve healthcare access for many rural residents. However, due to many rural communities being geographically isolated, they lack the technological infrastructure to support such services. Many rural communities have inadequate structures or resources for regular telephone, cellular service, or internet access. About 25% of U.S. households do not have internet access, and about 16 million rural residents do not have access to broadband internet. I thought it was interesting that only about 10% of those on tribal lands have access to broadband internet. So in many of these areas that don't have the infrastructure to support internet or cellular service, many have to rely on satellite for their internet provider. However, satellite is very costly, and which makes it an unaffordable option for many rural residents. With the new innovations in technology, there is the potential to use telemedicine to improve healthcare access for many rural populations. However, with many still being geographically isolated, they lack those infrastructures to provide the internet service or cellular service to run these telemedicine programs. So a lot of rural areas are using this telehealth system more for data collection rather than direct patient care. Cost of implementing telemedicine can be costly, ranging anywhere from $18,000 to $20,000, and a lot of rural facilities lack the financial resources to implement or maintain the systems with hiring an IT specialist or so forth. Even though most people now are starting to be a little bit more acceptive of new technologies, there is still some professional acceptance of using a new technology like telemedicine, which can create a barrier to its use. There is also some barriers or some concerns with there being a lack of national standards or regulatory agencies that are focused on privacy and security of the data used in telemedicine, or things like HIPAA and fraud and abuse of the system as well. The potential to expand the primary care model to use APRNs could drastically reduce the healthcare provider shortage by 2/3. If APRNs could effectively be integrated into the primary care role, the primary care shortage in 2020 would be estimated at 6,400. Changing policy to reduce the restrictions on APRNs is imperative to reducing those healthcare provider shortages. There is also government and financial incentives and reimbursements that help recruit providers to rural areas. However, many of those have limited contract timeframes, and retention of these providers is sometimes difficult after the contract terms have been met. Other recruitment and retention strategies should be used to help retain those that are already providing care in rural areas. There are some educational and training that specifically address rural needs. The VA offers a rural health training initiative that helps train health professionals to spend part of their time working at a rural VA facility under the guidance of a VA preceptor. The mix of academic learning and hands-on training will help the provider get a better understanding of rural health care, rural veterans, and the VA health system. Most colleges with NP programs, about 80% of them, integrate some care about providing it to underserved populations. And about half of them integrate some content into providing rural health care. However, there are very few NP programs that specifically address rural health care. One college in Pennsylvania recently received a HRSA grant that was able to train 20 of their family nurse practitioners to train as a primary care provider in a rural area. The University of Eastern Kentucky offers a Master's of Science in Nursing Rural Health Family Nurse Practitioner. So there are a few education programs that directly focus on rural health care, but they are few and far between. Expanding public transportation is one intervention that some cities have been able to do. but most of the time that is cost prohibitive to most rural communities. There are also transportation benefits through insurances or Medicaid. However, there are often limitations in using these services. For the Medicaid transport, rides must be booked at least 5 days in advance, and it doesn't include secondary stops, like stopping at the pharmacy to pick up prescriptions. Other transport services may only operate a few times a week or have set routes or times that may not correlate with appointment times with certain healthcare providers. Medication barriers are starting to be improved with home mail delivery systems, but most rural residents are still struggling if they have transportation barriers in obtaining their medications. The Missouri Rural Health Association recently tried a pilot program called HealthTran, and it trained clinic and hospital staff to ask patients when making appointments if they needed a ride to their next upcoming appointment. If they required a ride, they would be referred to a mobility coordinator who would assess their needs and find a cost-effective transportation solution. Even though there were costs in providing transportation services and maintaining a staff to run the program, they showed a positive return on their investment. They estimated that for every dollar invested, the return to the hospital was $7.68, and in the clinic setting, for every dollar invested, it ranged from $3.46 to $5.20 return on their dollar invested. In this literature review, none of the nursing-related articles mentioned any current interventions in improving the technology infrastructure and internet access in rural communities in the U.S. However, other technology-based articles refer to expanding internet service by developing smart cities or expansion of Google Fiber, for instance. There are also federal reimbursements to rural facilities for implementing telehealth. The more this program begins to be used, the more potential there may be for reimbursement, which could help stimulate growth of rural healthcare provider communities. There was a positive return on their investment. For every dollar spent in implementing telehealth, $11.50 was saved in travel and child care expenses. Another intervention that some rural areas are using is that of a town hall meeting. In a town hall meeting, the healthcare providers, health administrators, physicians, nurses, technologists all attend a community town hall meeting to discuss and answer any questions or concerns the community might have, and then discuss what technologies there may be available to them. And this simple action of community communication can help assess if any modifications are needed to implementing a new health technology or using it better. Some of the limitations I found in this literature review were that a lot of the research used had limited geographical data and used relatively small sample sizes. There was also a limited focus on a specific health outcome in saying, how does this transportation barrier affect diabetes management? A lot of the research was very general regarding stating these are the barriers identified that affect rural areas. There was also very limited data on specialty populations in rural communities like Native Americans, the disabled, or the elderly. I also found there was very limited data besides in technology resources or magazines that discuss how to improve the overall internet and cellular infrastructures to better address these healthcare needs. As a doctoral prepared nurse, I plan to work in a rural environment. So using educational resources as a foundation to how to address the social determinants of health in a rural area will be very important to my future practice. I think having an understanding of my own ethnocentric bias is important to being able to provide culturally competent and sensitive care. I would also like to promote involvement in the community by using town hall meetings as well as encouraging those of the community to pursue healthcare careers. I could do that by offering job shadowing in the clinic setting. I also would like to identify specific health outcomes that are tailored to each individual patient and identify a care plan that could specifically address the social determinants of health.